morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences of the ACNS webinar. Welcome back to yet another edition of very educational lectures for you. The speaker for the first session of today is our honored guest from India, Professor Vijay Shekhar. Professor Vijay Shekhar is a professor and head of neurosurgery at the Andhra Medical College, Visakhapatnam, India. He is an important member of the Neurological Society of India as well as the Neurotrauma Society of India. He is a central working committee member of the Indian Medical Association. He has received several awards and honors for his outstanding contribution to neurosurgery in his country. He is also a noted author with several publications in various peer-reviewed journals. In this pandemic, he has treated perhaps the largest number of patients with mucormycosis in the country, and we're extremely honored to have him today with us in our webinars, and he'll be sharing his experience with us about the management of Rhino, Orbito, Cerebral Mucomycosis. The speaker for the second session of today is our honored guest from Taiwan, Professor Sanford Su. Professor Sanford is the director of Neuro-Oncology, Cerebrovascular and Skull-Based Neurological Institute at the Taipei Veterans General Hospital, Taiwan. He is also the associate professor at the National Yangming Chiao Tung University. He is a visiting professor at the University of Virginia since December 2013. He was the vice secretary of Taiwanese Neurosurgery, Neurospine Society, and the Taiwanese Neuro-Oncology Society. He was a former fellow with Professor Ali Chris, Professor Al Mufti, and Professor Yashjil. He is a noted author with several publications in various peer-reviewed journals and book chapters. We are extremely thankful to Professor Sanford Su for accepting our invitation to be a speaker at our webinars. And today he'll be talking about pretemporal transcavenous approach to invasive pituitary macroadenomas. The chair for the first session of today is our honored guest from India, Professor Girish Menon. Professor Menon is the professor and head of Department of Neurosurgery at the Kasturba Medical College, Manipal, Karnataka. Professor Menon has a long distinguished career at the prestigious Sri Chitra Institute of Medical Sciences, Trivandrum, prior to his present appointment at Manipal. He is a world-class surgeon, also a great orator. He is an invited faculty to various workshops and conferences all around the world. He has published several articles in various peer-reviewed journals worldwide. He is an important member of the Neurological Society of India and has been on the administrative side since a very, very long time. We are extremely honored and thankful to him for accepting our invitation to chair the session of Professor Vijay Shekhar. The chair for the second session of today is our honored guest from Chile, Professor Jorge Mura. Professor Mura is the professor of neurosurgery at the University of Chile. He is also the chief of cerebrovascular and skull-based division at the Department of Neurosurgery at the Institute of Neurosurgery, Asenjo. He is the president of the Chilean Society of Neurosurgery. His research and clinical interests are focused upon skull-based surgery and cerebrovascular surgery. He is a noted academician and a proficient surgeon who has published several articles in various leading journals. We are extremely honored and thankful to him for accepting an invitation to chair the session of Professor Sanford Su. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome all the chair speakers and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Girish Menon.
Thank you, Dr. Raja. That indeed was an express introduction. So it's an honor and a privilege. Thank you, ACNS Education Society. Thanks to Dr. Raja again. Raja, if you permit, I'll just share my screen. So the last 2 years have been a nightmare for the entire medical fraternity thanks to the COVID infection. If it was the pulmonologists and the intensivists who were affected in the first wave, we started getting our neurosurgeons started getting our share during the second wave, and that was in this form, in the form of mucormycosis, an opportunistic infection which classically affected post-COVID patients and especially the immunocompromised ones. Now, there was a triad of presentation for this particular infection. Phase 1 or stage 1 would be the nasal part, stage 2 would be the orbital part, and stage 3 would be the cerebral part. And the manifestation could be umpteen, all the possible complications that you expect in the ENT part, the nasal part, the orbital part, including loss of vision, and of course, if it left untreated, it would slowly creep into the brain and cause devastating complications. Now, this was particularly common in India and I guess other developing countries. I'm not too sure we'd had too many publications on this from the Western world. Myself here at Manipal, we unfortunately had encountered only 4 such patients with cerebral mucormycosis, although our ENT colleagues and our ophthalmology colleagues got plenty of Rhino Orbito complications. My personal experience is limited to just operating on 4 cerebral mucormycosis. Surgical debridement and maximum possible clearance is the optimal treatment of choice, followed by antifungal, and that too needs to be given for a very, very long time. Now, I would be quoting textbooks and my limited experience, and the best person to talk about this rather complicated neurosurgical complication of a fungal infection would be Dr. Vijay Shekhar, whom I am told has the single largest series of operated cerebral mucormycosis in our country. He has operated over 60 cases of mucormycosis. Dr. Vijay Shekhar, as Dr. Raja pointed out, is a renowned faculty and with multiple publications. And this particular COVID pandemic has portrayed another facet of Dr. Vijay Shekhar in the form of successful handling of cerebral mucormycosis. And without much ado, let us hear from him right from the champion's mouth. So Dr. Vijay Shekhar, over to you. Eagerly waiting to listen and learn from you about Rhino cerebral mucormycosis.
Thank you very much. Very good evening to you all. Warm welcome and greetings from Andhra Medical College, Visakhapatnam, India. Friends, the topic given to me is the treatment of Rhino Orbito cerebral mucormycosis. However, my outline of presentation will be a brief overview and introduction, and the various spectrum of presentation. Of course, in 4 slides, Dr. Girish has effectively conveyed what are all the various manifestations. I will be only showing a varied clinical presentation, mostly in pictures. The spectrum of presentation and then CNS implications, the various neurosurgical procedures we have adopted, followed by some of the examples, then some of the non-neurosurgical procedures, and what practical issues we have encountered, and then the guidelines formulated and a discussion. This will be the outline of my discussion today. Friends, as all of you know, the world has seen a pandemic starting in the ending of 2019 and in the 2020 and 2021, there were peaks, first wave and second wave. As rightly pointed out, there was not much of involvement of other systems except for the morbidity and mortality associated with the COVID in the first and second waves. However, at the end of the second wave, we got a new presentation in the patients who are being treated for COVID or those who are discharged from the COVID. We had the experience of treating more than 6,000 plus cases of COVID-19 in a dedicated block in the tertiary care hospital of our medical college, that is Andhra Medical College, the King George Hospital, Visakhapatnam. In the second wave, that is approximately May and June of 2021, some of the patients have presented with different manifestations, and they were evaluated and found to be what was thought to be previously an opportunistic rare fungal infection, that is mucormycosis. We thought this is a rare presentation of the COVID. And all of a sudden, there was a sudden surge in the cases, number of these cases. And the neurosurgeon was given the task of a comprehensive care. The physicians were roped in, all the other specialists, the ENT surgeons, ophthalmologists, plastic surgeons, everybody has been taken into the fold, and we started treating these cases. So with these, we have started analyzing these, and initial few cases, as I told, the first 2 cases we have observed along with the COVID-19 infection in the dedicated block. Those patients who are entered into the COVID ICUs presented with facial-maxillary swellings and reduced palpebral fissure, orbital pain, and these were evaluated. After these few cases, the patients who are getting discharged from the dedicated block of the COVID, they are again representing to the hospital with various other manifestations, that is within 3 to 6 weeks from the discharge. And most of them are diagnosed and responded well for the treatment of the medical treatment of the mucormycosis. These patients who are treated medically for the mucormycosis again presented with some of the surgical lesions, and then we started treating them surgically, predominantly by the ENT surgeons, then by ophthalmological surgeons, and then neurosurgeons. Then these patients were continued with amphotation with the antifungals. Then we got various recurrences, redo surgeries, and lastly, for the mutilating and deformities, for the plastic and reconstructive surgeons, they have come in. Friends, just to brief you, the mucormycosis is the fungi of the order Mucorales, and it is the basic pathology is angio-invasive disease. The Indian Council of Medical Research, the ICMR, has given a nomenclature that is COVID-associated mucormycosis. And among this COVID-associated mucormycosis, the most common is the ROCM, that is Rhino, Orbito, Cerebral Mucormycosis. The other forms are, however, common in the pre-COVID era. So basically, what was thought to be a very rare disease, an opportunistic infection in the immunocompromised in the pre-COVID era, has turned out to be almost an endemic disease in the post-COVID period in our parts. We have till now, till the end of January 22, treated 440 cases of mucormycosis, out of which 246 are operated. But these 246 are inclusive of the predominantly by ENT surgeons, the paranasal sinuses and nose, then ophthalmological surgeons, and the neurosurgical cases are, we have treated 66 cases of with intracranial involvement. Among these, 31 cases are managed conservatively, mostly because of the dural enhancement, the extradural granulomas and cavernous sinus involvement, and so on. 35 cases were operated among the 66 cases. So these are the census of the cases operated in the neurosurgical department. Several factors are implicated for the etiology: contaminated humidifiers, frequent steam inhalation during the COVID-19 treatment, repeat use of masks. However, none of these have been proved so far, no publications so far. The associated comorbidities and like diabetes mellitus, immunosuppression, and some of the drugs are some of the other factors implicated. The basic pathology being an angio-invasive disease, there is a contiguous spread also. Initially, the paranasal sinuses are involved. Then from there, the disease extending into the orbital, from there to the intracranial compartment. So this is how the spread of mucor is going on. And the ethmoidal sinuses, from there to the frontal lobe abscess or temporal lobe or abscess, and then from the frontal sinus to the by contiguous spread to the frontal bone osteomyelitis. So these are some of the varied presentations. So according to the site of infection, the presentations varied, and the most common is the nose and paranasal sinus involvement. You can see the swelling of the cheek, the ocular and orbital involvement, the pulmonary involvement, then the cutaneous involvement, then the cranial involvement. So this is the type of presentations which we have encountered during our treatment. As was shown already, these are the spectrum of presentation, the symptoms. The nasal symptoms included nose blocks, nasal discharge, swelling of the cheek, and heaviness of the sinuses, mild headaches, numbness of the cheek, especially because the involvement of the intraorbital nerve and so on. Then coming to the oral cavity, loose teeth, toothache, and pyuria, crust formation, necrosis of the palate. And ocular manifestations are pain in the eye, the narrow palpebral fissure, watering of the eyes, chemosis, restricted eyeball movements, double vision, and some patients have presented with loss of vision as the first manifestation. Coming to the cranial manifestations, there are no specific symptoms except for a moderate to severe headache or hemiparesis. Only on investigation and evaluating these patients, we could confirm that these patients were suffering from mucormycosis. The other rare entities which we have encountered are the cutaneous and pulmonary forms. So this mucormycosis has been classified as a possible, probable, and proven. So this I will be showing again at the end of my presentation. But however, the main point to be taken is, once the patients present with any symptoms suspicious of mucormycosis, that is within 6 weeks of discharge from the COVID, if the patient develop any of these new symptoms pertaining to these systems, we should empirically start the medical treatment without waiting for confirmation of the diagnosis, because waiting may lead to rapid progression and worsening of the symptoms. So the most common antifungal used during this endemic was amphotericin B. As you can see, amphotericin B was very toxic, especially nephrotoxic, with associated metabolic side effects like hypokalemia. Hence, it is given as an infusion in the dextrose and with the dose of 5 to 10 milligrams per kg body weight, and oral forms, the posaconazole was used. Once the patient comes, simultaneously we start the treatment and send the patient for the cultures and confirmation. You can see the first slide, that is the demonstration of the fungal hyphae, that is the culture. The second one is the culture in the bottle, and the lower two images, you can see the broad acceptate fungi which are seen on the histopathological examination. So what were the initial challenges we faced? Suddenly, as I was mentioning, the patients were getting discharged from the COVID block and again approaching the hospital with various symptoms. The availability of antifungals was a crisis, and the number of vials available are less, and the patients coming are more. So we have to screen, we have to rationalize, we have to prioritize which patient needs more parenteral antifungals and which patients can be managed with oral antifungals. Similarly, initial thorough debridement of the nasal cavity and nasal sinuses, then the crust formation, sloughing and necrosis necessitating revisions and multiple surgeries. Then this amphotericin B used to be continued for long term, and we were cautioning and repeatedly doing the renal function tests, and some of the patients succumbed because of the hypokalemia. So these patients were treated in ICUs. So these are some of the challenges we faced. And ultimately, once the patient survived, there was a lot of mutilation and disfigurement. These patients were taken care by our plastic surgery colleagues. So these are some of the patients. You can clearly see the involvement of the orbital involvement, narrow palpebral fissure. There is a chemosis, completely ptosis, and bilateral involvement. This is one example where the patient was started on oral posaconazole. But by the second day, there was a rapid progression and worsening of the symptoms. So because of non-availability or restricted availability, the patient was started on oral form initially, but immediately once we saw the worsening, she was initiated with the parenteral form. By the day 3, within 24 hours of receiving the parenteral amphotericin B, the patient started improving, and this is a picture on the day 3. Similarly, some of the patients have presented with restricted eyeball movements. These patients, because of the intact vision, and though there is retroorbital granuloma seen, our ophthalmological colleagues, they have introduced a TRAM, that is transcutaneous retrobulbar amphotericin B injection. And luckily, some of the patients have improved. You can see the clear regression of the symptoms in the second picture. And this is another poor patient who has very rapidly deteriorated with his vision in the both eyes, extensive chemosis in both the orbits, and we are continuing in spite of giving the amphotericin B, patient was worsening. So immediately we have taken the help of plastic surgeons. You can see the medial orbitotomy. So he was taken for surgery, a scleral guard was kept, and a medial orbitotomy was done, and the retroorbital granulomas were removed. And luckily, this patient has gradually improved. Not all the patients are so lucky to have their vision preserved, and some of the unfortunate patients, they lost their vision. So in spite of the aggressive treatment with antifungals and supportive treatment, they lost their vision. To prevent the further rapid spread, we had no other option but to do exenteration. So in the exenteration, along with the extraocular muscles, the extra retroorbital fat, everything have been removed. This, you can see the entire globe has been removed, and this is the eyeball. This is the, and see, this is the amount of the disease. So many patients. At any given time, we used to have 4 to 5 patients who are unfortunate and got their orbital exenteration done. This is only to show the severity of the disease in our area as an endemic. So these are some of the examples of the orbital involvement. So this case is an example of pyuria. You can see the pus pouring out with loosening of the teeth. There is a swelling of the jaw, fungal osteomyelitis. Again, palatal necrosis. Some of the patients presented with were actually some patients presented with fistulas also, extensive necrosis. So these are some of the things. And our ENT colleagues, they have done, along with the endoscopic surgeries, open surgeries were also to be performed. And this is an open maxillectomy. You can see the orbital exenteration and maxillectomy, same patient. Several patients, these combination of surgeries had to be done. And this is again, you can see a modified Weber-Ferguson, a jet-shaped incision. So this is the intra pictures and the post-operative picture. This is the excised specimen. You can see the necrotic material of the excised maxilla. And though it was rare, we got surprisingly a significant number of cutaneous involvement. You can see in the first picture, the lower lip, you can see the black scars, and similarly simultaneous involvement of the skin of the sinus, the skin of the cheek, and then orbit also has been involved. Similarly, you can see the changes in the lower lid or the cheek. An extensive patient was started giving antifungals at some other place and came to our department with this much of extensive lesion, skin lesion. The same patient, a debridement was done by plastic surgery department, and the patient have improved. And this is the rotation flap. This is after the surgery. And one unfortunate patient presented with a black pustule, rapidly worsened, and the Ashar patient was initially done an below elbow amputation, then an above elbow amputation. You can see the shoulder here. Even the above elbow amputation, patient have not shown any improvement and rapidly worsened. And unfortunately, the patient developed severe breathlessness and was admitted into, shifted to ICU and succumbed there. So these are some of the examples of nasal and orbital involvement of the mucormycosis. That covers the rhino and orbital part. And this was the first case which was operated in our King George Hospital. The same patient whom I was showing in the previous, the involvement of the lip here, cheek and eye. There was a cheek has been exenteration of the orbit, excision of the wide excision of the lesion of the cheek, and here lip also has been shaved, and this is a post-operative image. So the LPCB, the lactophenol cotton blue appearance of the fungal elements. So this is the post-operative picture. This is the team. As I have been mentioning, this is not a single person's treatment. It is a teamwork. The plastic surgeons, the ENT surgeons, ophthalmologists, basically all supported by all the patients with supportive care of the physicians and the supportive lab. This is the teamwork, and this is the first case which was operated in our department. So coming to the neurological involvement, basically, as I was mentioning, they were either with moderate to severe headaches or hemiparesis. On evaluation, we had radiologically either meningeal involvement or early cerebritis features, which were managed conservatively, or a frank abscess formed endoparenchyma, either contiguous or deep-seated, and osteomyelitis was skull bone. So these two, the brain abscess and osteomyelitis, are the entities which necessitated surgical management. So these are some of the images. You can see the basic frontal abscess, irregular abscess. Endoscopic images where the sickle knife has been used to drain the pus and the abscess cavity, and this is a post-operative scan. A small video of the same patient. You can see in the MRI scan the basic frontal region, the irregular abscess. The initial ENT paranasal sinuses debridement was done, and using a microdebrider, and then once the dura is exposed, using a sickle knife, the dura has been incised with you can see the pouring out of the pus. So the extensive pus was coming out, and the abscess cavity has been entered. It was drained, and in the first case, we have only drained the abscess. Subsequently, we thought the same fungal, the abscess cavity was irrigated and then irrigated thoroughly, and the continuation of the amphotericin B, the patient improved post-operatively. So this is another example where extensive involvement of the paranasal sinuses, and there was an extent, you can see the breach there, and also a thick-walled abscess in the temporal pole. So this, because of the extensive disease and also thick-walled abscess, an open craniotomy and excision of the abscess cavity was done, and this is the post-operative image. Another example of a patient, again with an irregular basic frontal abscess involving the both lobes. The patient again treated endoscopically, and this is the post-operative scan, and the patient have improved. This is another video, a small video. Again, the same, after paranasal sinuses decompression, the dura was incised, and here, instead of a frank pus, we could see fungal granuloma in this particular patient. You can see the fungal granuloma being removed. The abscess cavity irrigated with the amphotericin, diluted amphotericin B. And thorough debridement was performed. So these are the post-operative pictures. But friends, this is not the end of the story. This lady who was operated as a very first case, you can see the lesions healing here, but the patient complained of severe headache within 1 week of her first surgery. Similarly, the other person also was discharged home after paranasal sinuses decompression, but presented with a forehead swelling. So the story is continued. This is the picture of the MRI image of the lady. You can see a temporal cerebratis here, vague abscess cavity here. But while still on antifungal treatment, within a week, she developed a severe headache, and on evaluation, you can see the extensive development of the abscess in the temporal pole. So we thought the patient already undergone excision of the cheek, exenteration of the orbit, and how best to minimize the morbidity. Then we thought the orbit which has been exenterated, we can approach to the same thing. Through the superior orbital fissure above and below, if we can drill the sphenoid bone, we can enter either into the frontal cavity, frontal lobe, or the temporal lobe. So initially we have just opened the eyelids, and we have drilled the sphenoid wing there. And this is the transorbital drilling. This is the technique which we have adopted. And you can see by simply inserting the brain cannula, we could get the thick creamy pus here. And because of the thick nature we have irrigated, we have kept a drain post-operatively. And this is the immediate post-op picture of the patient. Another patient developed a deep-seated abscess. And because there is we thought this patient also kept conservatively, but there is an extensive edema. So we thought we can go ahead with a decompressive craniotomy because of the extensive edema, and the abscess was drained using an infant feeding tube because the pus was very thick and could not be drained easily. So that was a deep-seated abscess. Again, we encountered different patients, different presentations. A patient has presented with an abscess with irregular abscess cavity, which is onto the surface. So we thought we can avoid a conventional craniotomy, and we have did a supraorbital mini craniotomy, and you can see the size of the craniotomy, just 3 centimeters craniotomy, and this is the abscess cavity. The fungal granuloma and the pus have been evacuated, and the patient has improved. So these are some of the patients who were discharged after the initial treatment, went home, and then presented with forehead swelling. I think it is appreciated very well here in both the films. So then we thought we re-evaluated the patients. The CT scan was showing extensive destruction of the bone, extensive destruction of the frontal bone in this case, and we have encountered different such lesions, and almost 19 such cases of fungal osteomyelitis of the skull bone. So this is the, you can see the fungal extension of the disease going up to the root of the nose. This is a postoperative bone which has been removed, and this is the postoperative CT image and X-ray. Postoperative defect, the patient was doing well. This is again another patient. You can see the same thing in the 3D reconstruction bone windows. These are the intraoperative. You can see, I think it can be appreciated, both the outer surface and the inner surface. This is there is a clear-cut demarcation in some of the cases, and we have taken care that at least 1 to 1.5 centimeters of the normal bone, normal skull bone was excised along with the involved bone. So that is the actual meaning of debridement. Even the normal part tissue was also removed. And this is another example. I think in the third picture, you can see this is the suction showing the dura here, suction kept out the dura. And this is the almost 1 to 1.5 centimeters thick fungal granulomas, extensive granuloma on the dural surface. So this is the bone, outer surface, inner surface. You can see that even the inner surface, there is some granuloma attached there, granulation tissue. So we thought we have denuded the dural surface. We thought along with the parental antifungal, why can't we keep some topical antifungal? So this is a gel form which is soaked in an amphotericin-based solution kept over the dural surface. You can see all the 3 different images of the CT scan here. An extensive involvement in the midline. Here in this picture, you can see the supraorbital rim is involved, some of the normal bone, and then extensive involvement. So these are something like skip lesions. So 19 such cases we got and operated. All the bones thus excised have been sent to the pathology department of our medical college. And these are the slides. You can see this dark one is the bony spicule after demineralization in the nitric acid solution. This is the bony spicule, and amidst that, you can see these are the broad accepted fungal hyphae. So this is the photomicrograph obtained from the Department of Pathology. I acknowledge the work done by the pathology department. Similarly, this is under low power. These are the dark ones are the bony spicules. And these are the chronic inflammatory cells. Again, the fungal, these are the fungal elements. So this is the chronic fungal osteomyelitis. So these are the photomicrographs. So friends, as I was mentioning, we have operated for 2 entities, that is the brain abscess and osteomyelitis. We have total number of 16 brain abscess treated and 19 cases of osteomyelitic involvement of the bone. And these are the various neurosurgical procedures we have adopted. Endoscopic drainage of the abscess along with endoscopic sinus surgery was performed in 6 cases, and 4 cases each were performed with transorbital drainage of the fungal abscess. This is an innovative one through the extended globes, and the craniotomy and excision of the abscess were performed in 4 cases. 1 case, a supraorbital mini craniotomy has been performed, and decomposed craniotomy and drainage of the abscess in the thalamus and basal ganglia 1 case, and excision of the bone 19 cases. So these are the cases and different procedures which we have adopted. These are the examples of the cases after removing of the frontal bone. These patients are under regular follow-up. All of them are kept on amphotericin B and later converted to oral posaconazole. And friends, this is my department at King George Hospital, Andhra Medical College. Our professor, head of the department, and all our residents and faculty. This was the teamwork, and with that as a team, not only our department, with all the other departments, we could do this. Friends, these are all not simple procedures. As I have been showing, some patients almost more than 50% improved with and went home comfortably with mere conservative treatment. But some of the team effort is very important in these cases, and significant risks were associated. Initially, when these cases were taken up for surgery, there were several doubts in the surgeons and the anesthesia and everyone's mind. These patients, how active is the COVID in these patients? How safe it is to perform surgeries in these patients to the medical team? So amidst all these, we could do, and we understood there are very few factors which are in the hands of the surgeon to control. And however, we give antifungals and take the care. Ultimately, there is no significant mortality. We have only 3 cases of mortality in the 66, but there was significant morbidity. And these are some of the innovative things which we have adopted, either a transorbital excision, transorbital drilling and drainage of the pus, a mini craniotomy, endoscopic assisted drainage of the pus, decomposed craniotomy and aspiration, and topical infiltration of the lipoable amphotericin B. Still, there are several unanswered questions. This pandemic was world over. Even in India, there was first, second, and waves have completed, and another wave is going on. But why these mucor cases are not seen in rest of the world? Even in India, why only few states like Maharashtra and Telangana, Andhra, and some of the southern states? And even in our own state, there are pockets of places, the North Coastal Andhra districts, and similarly. So these are still unanswered questions, and several patients, almost all the patients are diabetics, although several patients are immunocompromised or other things, but still we have to find out the causes. With this experience, friends, the several scientists in India, they have been working, and the several articles have been published. The Indian Journal of Ophthalmology, they have come out with a staging of the Rhino orbital cerebral mucormycosis. They have staged into 4 stages, as was mentioning by Dr. Menon. It was when the nasal mucosa is involved, it is stage 1. Very simple, I will tell. It is only 4 stages. Nasal mucosa involvement is stage 1. When the paranasal sinuses are involved, it is stage 2. When the orbits are involved, it is stage 3. And when there is cranial intracranial involvement, it is stage 4. For stage 1, 2, and 3AB, it was conservative management. Once there is an extensive involvement of the orbit, the fungal disease going beyond the orbit and involvement of the intracranial part, then we had to resort to surgical management. So this is the algorithm. This is the algorithm developed, which is already published in the Indian Journal of Ophthalmology. As I was mentioning, these are possible, probable, and proven ROCM. Possible means whenever the patient comes with a symptom, clinical setting, but still on examination, there are no findings suggestive of direct nasal endoscopy. There are no findings suggestive of involvement. It is only possible. When the patient presents with symptoms and on examination, there are findings suggestive of phenomenon, then it is probable. probable case of ROCM. And a proved case of ROCM is, along with the clinical manifestation, once we demonstrate the fungal elements either by potassium hydroxide mount or culture or histopathological examination. So once it is confirmed means proved. So once it is probable or proved case, we should not wait till the other manifestation. We should immediately start the empirical medical treatment, that is the amphotericin B. This is the flow chart. And once there is a patients are in the up to stage 3A, B, we can give topical amphotericin B, irrigation of the nasal cavity or retrobulbar amphotericin B. But once there is extensive disease, stage 3C, stage 4, that is intracranial involvement, we have to go for surgical involvement. So this is the staging and some of the involvement. Friends, this is almost the neurosurgical intracranial involvement. I think within a couple of minutes, I will be finishing my talk. But these are some of the interesting pictures, though not exclusively to neurosurgical. This is a poor patient whose nasal debridement was done, orbital exenteration done, maxillectomy done, but patient presented with extensive pouring out of the pus. In this video, you can see there was nothing left for the patient to hemispace. So almost the entire gauze piece was coming out through that thing. So this is the first image. You can see the after excision of the exenteration, there was a pus, there was a regular drainage and regular dressings. Somehow the patient has improved, and this is a Weber-Ferguson incision impact subsequently. And for this patient, our plastic surgeons have come into place, and they have taken used a forehead rotation flap. You can see this is the forehead of the frontal for occipito frontalis that has been used to fill the gap of the orbit, and the forehead defect was covered with a partial thickness skin graft. Of course, this as a teamwork only we could do, and they have cut this, and this is the postoperative. I don't have the latest film, but this is another patient on whom the temporalis flap has been developed through a lazy S incision through the supraorbital skin ridge. The muscle, this you can see the nicely dissected temporalis muscle, fan-shaped temporalis muscle. It has brought out beneath the skin ridge, and this is a postoperative closure. So, friends, these are some of the cases which we have encountered. These are a few interesting cases. Oropharyngeal fistula patient coming presented with whatever they are drinking, they are coming out through the nasal cavity. And for our facial surgeon, they have used the obturators to conceal the defect, and prostheses have been prepared. And so this is the work we have done. And friends, the support of the microbiology department, as the first one is Cerebral dextrozaga. This is the culture. Some of the patients were negative for the potassium hydroxide mount. Even though fungi are not demonstrable, if for every patient the swab has been kept for culture, and some negative patients have also demonstrated Cerebral dextrozaga culture positive. Similarly, the lipophenol cotton blue appearance. These are some of the microbiology pictures. These are some of the pictures taken from the pathology department. So friends, I acknowledge profusely all the people, all the departments, the anesthesia department, the ophthalmologists, the ENT surgeons, plastic surgeons, and the Department of Neurosurgery, guided by the general physicians and other supporting departments. So this is my medical college at Andhra Medical College, Visakhapatnam, and thank you all for sharing our experiences in this pandemic. Thank you.
Thank you, Dr. Vijay Shekhar. An excellent presentation and exhaustive review of the topic with excellent clinical illustrations, both patient as well as radiological. And I don't know, hats off to you and your team. I mean, my head bows in admiration and humility. In fact, the pictures of the patients are really depressing and devastating consequences of mucormycosis. I don't think I envy you and your team for being there, but I have to admire the great work that the entire team has done. I see Dr. Vani has raised a hand. So will Dr. Vani, if you could just post that. I don't, yeah, there is one question. Dr.
Just
Muthu.
1 minute. I am Dr. Varaprasad, sir. HOD.
Yes, yes, Dr. Varaprasad, yes, please.
Good evening, sir.
Sorry, is our head of the department, sir.
Yeah,
head of the department.
Prasad is the head of the department.
We are together. Sir, it's not envy. We are forced to do the work, sir, because our center was declared as a state COVID center for nearly 5 districts. And nobody taken the cases in private sector or like that. And we are forced, and we are very thankful for our youngsters, young neurosurgeons, and all the team. We have done extensively. This is all original work, sir. Somehow we don't know, as the questions raised by our Vijay Sekhar, why it is more in second wave. Second wave, first wave it's not seen, and now also it's not seen, sir. Omicron in this sequence also we are not seen any mucormycosis. For the past 25 years, we didn't see even a single case. Now within 5 or 6 months, we have seen such a number of cases, especially intracranial, more than 60 cases we have recorded. So we have done so many innovative procedures also, sir. And with this, what others are thinking is the mortality, they used to think that is very high. But for us, fortunately, out of 60, only 3 were expired, sir. That too, deep-seated and extensive. But remaining patients are alive with minimum morbidity. And we are somehow we have to publish that one also. So usually mucormycosis is diabetes and all, they think its mortality is very high. But we got all evidences, patients are alive and they are coming and they are following also. In spite of extensive surgeries, they are alive, sir. That is another important thing we have to notice. We are very thankful for giving the opportunity.
Thank you, Dr. Varaprasad. I saw Dr. Vani had raised a hand for a query, but I don't see. And Dr. Manas in his comments has written about a query. Dr. Manas, do you mind typing the query? Then we could ask, or you could join as a panelist also. A comment, I mean, couple of comments have come in, Dr. Vijay Sekhar. Dr. Muthu wants you to definitely publish this. I'm sure this is worthy of publication. And Dr. Manas's query has come in. Any specific reason you preferred abscess drainage by transorbital approach? And yeah,
Good evening.
yeah. Continue, Dr. Vijay.
Good evening, Dr. Manas. Sir, it is only to prevent the already patient was mutilated and high morbidity. So this was the least possible, because the patients, almost all the patients, we have 4 cases we have done transorbital. This is the shortest possible distance, and without intervening, without transgressing any normal tissue. We have only sutured the orbits, the upper and lower lid have been sutured. By simply opening the suture, we can directly drill, and we are directly on the dura. So with a brain cannula, we can directly find. So this is the shortest possible thing without any further morbidity or damage to the patient. So that is the reason, sir. No other reason. Otherwise, we have to put a per hole or do another thing. That's all, sir.
Dr. Jogi also wants to share his appreciation. I have one question for you, Dr. Vijay Sekhar. How long do you continue this oral medicine after amphotericin? You said you give injection amphotericin and then you continue with oral. How long is the recommended treatment?
Sir, it was actually 6 weeks of the antifungals or till the regression of the surgical lesions. So what we did was, for all the patients, for those with extensive involvement, we continued the parenteral, that is the injectable amphotericin B, for at least 3 weeks. They need to be hospitalized. And those with moderate symptoms or those who are improving, we have converted them to oral antifungals, that is the postoperative. Even after discharge, we were following them every week with the function. And we have continued almost up to 6 weeks post discharge. So almost for 8 to 10 weeks we were giving this, and it was only radiological and further regular follow-up. Some of the patients were showing these remnants of the fungal granulation or the dural enhancement even in the post-op images. So we have not taken so far. Only one patient has come for the cranioplasty. So minimum 8 to 10 weeks we are continuing titering the patient's need and the renal parameters.
Thank you, Dr. Vijay Shekhar. Dr. Raja, you're cracking the whip here. Feel free to short.
Nothing like that. I
minutes.
think it's, yeah, we have time, 5 minutes.
Yes,
Just I would like to, one
Dr.
question
Vijay.
from me.
Yeah, I'll just Dr. Vijay Shekhar,
please.
one just quickly. Did you have the occasion to do CSF in any of these patients? Do they have meningitis as well along with abscess? And then Raja can also share a question.
No, as I was mentioning, though we have treated 19 patients, these are the operated patients with fungal osteomyelitis. Sir, I have not shown some of the cases where the base of the skull also has been involved. So for those patients, we couldn't go and drill that involved part. We cannot do debridement. So they were kept extensively, exclusively on the antifungus number 1. In 2 cases where there was a orbital exentration, through the orbital, I have actually that video for want of time I have not shown. I can share with you personally or keep it in the group. The orbital, through the orbit, we could see with each pulsation, the CSF was coming out. There was CSF leak initially. So immediately we called our plastic surgery colleagues. So they have done, we have taken all the conservative measures, elevated head and elevation, Dimox and all. We have kept the wound dry, and with little gel foam we have managed for 1 day. Immediately the next day, they have done this forehead flap. So once the muscle pedicle flap was done, the patients have improved well. Only one such case with extensive CSF and another case with mild doubtful CSF. Only 2 cases we have managed. Both of them recovered well with the plastic surgeon's intervention in 1 case.
Dr. Raja?
Yes, thank you very much, sir. 2 questions to you. First, at the onset, let me congratulate you for this wonderful work that you have done in your department. I'm really short of words to praise you and the wonderful work.
It is a teamwork, sir. It is a teamwork.
Professor Varaprasad, you and all the wonderful colleagues in ENT, ophthalmology, and all the plastic surgeons and all other departments. Really hearty congratulations. One question was that aspiration of pus versus craniotomy and excision of the abscess wall. Did you find any difference between them? And the second question is, you showed us a granuloma over the dura, where you had excised the granulation part and you put the gel foam with amphotericin B. Why didn't you consider an excision of dura and then a duroplasty along with it?
Sir, all these cases, especially the case which I have shown, the 1.5 centimeter thick fungal granuloma over the dura. Sir, we all know dura is a tough and natural barrier. All these cases were actually initially treated by endoscopic sinus surgery by the ENT people. They were discharged. Even though they are on antifungals, they have represented with extensive the swelling over the forehead and other extensive spread of the disease. So, in spite of antifungals, patient is worsening symptomatically. So, dura is a tough barrier. In spite of this much of disease, dura has not yielded. So we were very worried because there are nothing we have verified also. If we remove the dura, we might be doing, or rather, there may be a risk of fungal meningitis. So that is the reason why we have not opened the dura, not excised the dura and considered a duroplasty number 1. Number 2, that is the reason why we have taken the topical amphotericin soaked gel foam. And for your other query, that is the sorry for few cases were very thin-walled abscess where we considered drainage. The thick-walled abscess only we have excised. So we do not have actually that good number of for comparison in these, but however we are trying to find out any other causes also. But only thin-walled things we have drained with the abscess, and thick-walled one we have excised. That is the things.
Thank you very much. Any questions from my co-host, Libun Singh?
Thanks, Raja. Thanks, Prof, for very nice presentation. I first question, Professor, regarding the skull-based osteomyelitis, how much bone can we remove in actual sense? And what do you think that the possibility of using a hyperbaric oxygen therapy for chronic osteomyelitis? And do you think that the dexamethasone is the cause of the immunocompromised state in the treatment of COVID? And how can we enhance the immunity of the patient? Thank you.
Wonderful question, but a tough question also. Sir, this is the bone which I have shown all the 19 cases was the bone onto the surface, which is accessible for excision. We have come across 4 cases where there is involvement of the base of the skull. Even the actual sphenoid, body of the sphenoid also got involved. So even the bone, if the anticlinal fossa up to the cribriform plate, we have removed the bone endoscopically. All the bone, which is dead bone and necrotic bone, that has been removed. But beyond that, we have not gone, sir. We have not gone. And luckily with that, those patients stopped deteriorating, because it was only because most of these patients were asymptomatic, only radiologically followed up. And on serial scans, there was no further regression, further deterioration, nor patients have any symptoms, new symptoms. So that is one. The other thing is hyperbaric oxygen we don't have, sir. We don't have, so we have not considered that.
Thank you. Thank you very much. We can move on to our chair to hear his concluding remarks. Professor Menon, all yours.
Thank you. Dr. Vijay Shekhar, I just wish to echo the opinions shared in the chat box. Excellent presentation, and definitely it's worth publication, and excellent compilation, and hearty congratulations for this work to the entire team. Do request that this entire collection should be compiled and should be published preferably in this Asian Journal of Neurosurgery itself. A very great learning experience for all of us, because I'm sure none of us have had the personal experience of Dr. Raja. Dr. Manas wanted to share his experience. Is the time? He
may talk.
Small submission, sir. It is already accepted in JA Neurology India, sir. It is shortly coming in the
Sir,
journal.
we have sent it, sir. It is under peer review, sir. It is under peer review.
Okay, thanks, Doctor. Dr. Manas,
Yes,
Dr. Manas wanted to share his experience.
Yes, Professor Manas, you may kindly speak.
Yeah, I mean, so we of the 32 cases we had operated, we had 10% of the patients who did not have Rhino cerebral. It was like a hematogenous spread. We had multiple small abscesses like neurocysticercosis and 1 case of ventriculitis and 1 of a solitary abscess. So means hematogenous spread also we had. And the 10% who had bad outcome had multiple infection, like in addition to the fungus, they had bacterial infection also. So when we had culture of both bacteria and fungal positive, they did badly. And those 3 patients also had developed, because of posaconazole, they had developed low platelet counts. And means what as physicians don't highlight is posaconazole has almost 14% incidence of reduction of platelet count. And using posaconazole right, left, center also is very detrimental. And so that is what I wanted to warn about, because we had bad results with posaconazole, and whenever multiple infections and hematogenous spread also, even if we do not find any ENT, rhinocerebral thing, still one has to, we had to suspect, because we suspected, we could diagnose in 3 of them.
Yes, sir. Yes, sir. Thanks, sir. And also, sir, we also have now some of the bacterial also along with the mucor. But I have the data from the microbiology department. Along with the mucor, sir, surprisingly, some were Aspergillus species, some were Candida also. So there was mixed fungal infection also in few cases. So I have not shown purposely because of constraint of time, but there is a mixed fungal infection also in some cases.
Mixed fungal and combination with bacterial also. Yeah.
Yes, sir. Yes.
Yes.
Thank you, sir. Thank you for raising a good point. Yes.
Right. Professor Menon.
Thank you, Dr. Raja. I guess we are exceeded the time limit. Thank you for the opportunity. Thank you, Dr. Vijay Shekhar, and thanks to all the participants. Over to you. Back to you, Raja.
Thank you very much, Professor Vijay Shekhar, Professor Girish Menon, and all the distinguished faculties, Professor Varaprasad and Professor Manas, who joined us. So we have Professor Jorge Mura with us, who's the president of the Chilean Neurosurgery Association, who will be saying a short introduction about transcavenous pretemporal approaches to invasive macroadenoma. And he will invite intern Professor Sanford. So Professor Jorge Mura, all yours.
Thank you very much. For me, it's good morning, and now we will see the presentation of the Professor Sanford Su about pretemporal transcavernous approach to invasive pituitary macroadenomas. I think it's a very interesting subject about this very complex technical subject. And I don't know. I don't see the Professor Su is here.
Yes. Thank you, Professor Mura. Yes. I would like to thank Raja and Professor Mura for introduction. And could I share my screen now? Today, I would like to talk about the transcranial approach. I prefer pretemporal transcavernous approach to invasive pituitary macroadenoma. As Professor Raja and Professor Mura introduced, I'm from Taipei Veteran General's Hospital. Actually, I have done fellowship at UMass Little Rock between 2007 and 2009. And I had grade 3 mentors, Professor Yashagil, Professor Mapti, and Dr. Krisht. I learned a lot of concepts and techniques of modern microneurosurgery in Little Rock. I spent a lot of time watching their surgery and the work in the lab. Today, since I would like to talk the transcavenous approach to pituitary macroadenoma, so at the beginning, I would like to talk about the anatomy and how you can apply the important anatomy landmarks to your daily routine. And as I mentioned, I spend a lot of time in the lab doing dissection on the cadaver heads. But the anatomy is not the terms now you have to memorize. It is of most important that how you can apply this knowledge to your surgery. So as regards to cavernous sinus, as you know, once was deemed with no man's area, you have, if you are familiar with the anatomy of in or around the cavernous sinus, and nowadays it is now no more no man's area. And for even someone, for my teacher, Dr. Krisht or Dr. Mafti, actually it is a playground in their daily surgical routine. But how you can apply this anatomy to your daily routine? Based on my experience in the last decades, I classify the anatomies around the cavernous sinus into dura, bone, venous channels, and neurovascular structures. And several of the landmarks that you have to use almost in your surgical routines. For example, in dura structures, you have to deal the outer ring, the dura propria, the tentorium, and also for the bone structures, you have to deal with the zygoma, spinal wings, anterior clinoid, posterior clinoid, or even the anterior petrous. And not to mention the important neurovascular structure like the meningoorbital artery and GSPN, the intracavernous carotid, and the optic nerve to the even lower to the 7th and 8th cranial nerves. And for the cavernous sinus surgeries, it's like you play the building blocks. The black blocks is the basics for the cavernous sinus approach. The basics of the cavernous sinus surgery that you have to know how to peel off the dura off the lateral wall of the cavernous sinus And you have to know how to remove the anterior clinoid. And also you have to know how to deal with the ring, the dura structures surrounding all these neurovascular anatomies. And based on these techniques, then based on your gathering your experiences, so you can modify the basics of the Kevlar sinus surgeries according to the different pathologies. So you can do the transmucous cave for the trigeminal schwannoma, or you can do the more complex approach like the transmucous cave, transentorium, to different pathologies. And today I would like to talk about the transcavenous approach for pituitary microadenoma. And so based on the different pathologies like the column in the right side, and you can do different approach to different pathologies or different vascular lesions. For example, if you have the basic knowledge and concepts to do the Kevlar sinus surgery, you can deal with the spheno-rich meningioma, tuberculin cellular meningioma, or the some simple aneurysms like the pecan or paraclinal aneurysms. But for the most complex and difficult one, I believe is the large, huge petroclival meningioma or chordoma that you need to do totally unlock the Kevlar sinus and additional the anatomy surrounding the Kevlar sinus, like you do the transmucous cave, transtentorial, and transpersosal approach. So I classify, because for Kevlar sinus surgery, a lot of people, they are afraid because the complex anatomy and the highly demanding techniques. So people have a learning curve in Kevlar sinus surgery. I classify the learning curve into 4 levels. For the level 1, for example, you have to know how to open the superior wall of the Kevlar sinus. And level 2 is the lateral wall of Kevlar sinus. And level 3, you have to be equipped with the techniques to open the posterior wall of the Kevlar sinus. And the highest level is level 4. Now you can totally unlock, open the Kevlar sinus, and you can combine it with the anterior petrosal approach to deal with the complex pathologies like petroclival meningioma. So in each level that you have to be familiar with different techniques. For example, at level 1, that you have to open the superior wall. That means that you have to know how to do the dura peeling. You have to know how to remove the anterior clinoid and to deal with the outer ring removal and open the phosphor ligament and even the opening the Sylvan fissure. Then gathering your experience, now you can advance your level, push your boundary to the level 2. So you can open the outer ring, totally circumcise the outer ring, open the inner membrane, and open the lateral wall of Kevlar sinus. For example, open the Parkinson triangle. And up to the level 4, now you know how to open the superior, posterior, and lateral wall of Kevlar sinus. You can do the anterior petrosal approach. And even you have to localize the 6th nerve and open the duodenal canal. So today, actually, I just emphasize some simple key concepts and techniques of the Kevlar sinus surgery. The most first important point is you have to peel the dura, because all of you know that we have double layers of dura covering the Kevlar sinus. So you have to know how to peel the dura of the lateral wall of the Kevlar sinus to make anatomy shallow. Then you have to remove the bony blocks in the way to your view or to the pathology. For example, if you want to deal with the craniopharyngioma or some suprasellar pathologies, you have to remove the anterior clinoid. Otherwise, the bony is in the way to the view. Then the most important, you have to free all the neurovascular structure from where it is anchored to the dura. You have to free all these important structures so you can widen the windows between these structures, and you can minimize the traction stress over these structures. So you will have the minimal postoperative neurologic deficit. I prefer the pretemporal approach, and like my teacher did, Dr. Krish did, is a little bit different from the traditional terreonal approach. That usually you have to cut the temporalis muscle down to the zygomatic notch, so you can explore more of the space anterior to the temporal. Sometimes, if you need to totally uncover the lateral wall of the cavernous sinus, then you have to cut the zygoma to lower the temporalis down to the temporal base, so you can earn more space at the base and get more view through the cavernous sinus. And the first step to the approach to the cavernous sinus is to identify the dura fold, which is formed by the meningo-orbital artery. You cut the this dura fold, then you can expose the cerebral orbital fissure. Then you can find the double layers. You can always to localize the dura groove between these double layers of dura. Then this is the beginning. Now you peel the dura, the temporalis dura, off the lateral wall of the cavernous sinus. Usually I use in the sharp dissection to make the cleavage plane of the double layer dura, and I use in the blunt dissection to push the dura backward. You push the dura backward until you totally expose the clinoid, the tip of the clinoid, and until you see the trochlear nerve and the V1 and the V2 branch of the trigeminal. So in these steps, you finish the basic length approach to the cavernous sinus. If you want to do the more advanced cavernous sinus approach, then you have to turn your microscope to the middle meningeal artery, because you have to cut this artery to expose the V3, the so-called foramen rotundum and foramen ovale, sorry. Then you push the dura backward to expose the V3 and even the GSPN. You push the dura in the direction following the GSPN to preserve it. And in this way, you can also expose the anterior petrous region, the so-called Kawase triangle or Kawase rhomboid. Then you can totally uncover the lateral wall of the cavernous sinus, so you can see the anterior clinoid, the superior orbital fissure, the trochlear nerve, the V1, V2, V3, Gasserian ganglion, the macroscaphe. Since you have made a lot of space outside the dura, so-called extradural approach, then if you need to cut the dura, it's not like the usual way we just made the dura flat. You have to cut the dura along the seven fissure down to the base, then extend the dura incision bilaterally till the optic nerve until the tentorial incisura. So you can open the space without just with the intra and extradural space communicated. So you can see all the neurovascular structure that penetrating the dura into the cavernous sinus very well. As I have emphasized, for our cavernous sinus surgery, the most important concept and techniques is to free all these important neurovascular structure from the ring light surrounded by the dura structures. In this photo, as you can see, when the optic nerve penetrating the dura into the optic canal, there will be the phosphor ligament. surrounding the optic nerve. And there will be the outer ring surrounding the carotid, and also there will dural ring structure surrounding the oculomotor nerve. You have to free all these neurovascular structure so that you can widen the space between these structures. And also you can minimize the traction and the stress over these structures, and you can minimize the post-op neurologic deficit. So for example, you do the extradural approach and you cut the dura down to the base. You expose the optic nerve, the carotid, and you found there's a dural ring structure surrounding all these neurovascular structure. So you have to cut the phospholigament to free the optic nerve so that you can mobilize the optic nerve to widen the space between the carotical and optical window. So in this way, as you can see, you widen the window so you can easily to visualize the pituitary stalk beneath the optic nerve in the interpeduncular fossa. And also to deal with the pituitary microadenoma with suprasellar extension or the craniopharyngioma. In this way, you already free the optic nerve, so you can mobilize the optic nerve upward to widen the space between the optic nerve and the carotid artery, so you can see the anatomy very well. Even you can see the carotid in the opposite side, and also you can see the pituitary stalk very well. And actually, since you just put a little bit stress over these structures, it won't cause any severe post-op neurologic deficit. If you can free all these neurovascular structure from these ring-like, dural ring-like structures, so as you can see in this in this operative photo, you can totally expose the carotid in the in intradural space, in the clinal space, and even in the intracavernous space. So you can totally delineate the carotid. As you can see, this is a siphon, and this is intracavernous carotid by mobilizing the oculomotor nerve. But the first important step is to free the oculomotor nerve totally from the dural ring surrounding this nerve. So you can totally expose the carotid artery. So in this topic, I will do the transcavenous approach. As I mentioned, is at a level 3 of the cavernous sinus surgery. So in this level 3 surgery for invasive microadenoma, some key techniques that you have to know. The first one is you have to peel the dura off the lateral wall and with fully exposure of the lateral wall of the cavernous sinus. You have to remove the anterior clinoid because most of the invasive pituitary tumor, they extend upward into the suprasellar region, and the anterior clinoid is in the way. But in most cases, actually the anterior clinoid is already destructed, eroded by the tumor. Then you have to cut the phospholigament and outer ring to free the optic nerve and the carotid. As you know, the invasive pituitary tumor, the push optic eyes and upward. If you don't cut the phospholigament to free the nerve at the beginning, then when you pull the nerve, and you will cause the post-op the vision problem. Then most of the tumor, they extend posteriorly and also strangle the oculomotor nerve at the point where they enter the cavernous sinus in the cavernous sinus triangle. So you have to cut the dural ring surrounding the oculomotor nerve to widen the space between the trochlear nerve and the oculomotor nerve, and the oculomotor nerve and the carotid artery. And sometimes the tumor will extend along the sylvian fissure, so you have to know how to open the sylvian. And also, the tumor bulging out from the lateral wall of cavernous sinus. So you have to know how to open the Makos cave and dividing part of the tentorium to totally expose the interpeduncular or prepontine space. So this animation showed the growth pattern of the pituitary tumors. As you can see, most of the invasive microadenoma, they will extend superiorly into the suprasellar region and push the chiasm upward, or even go into the third ventricle. And the tumor will extend laterally to push all the nerves overlying the cavernous sinus in lateral direction, or even they go backwards positively and go backward beneath the mesiotemporal region. And the tumor may go downward to invade the sphenoid sinus or even the maxillary sinus. But for most of the cases, actually, I believe the people prefer the endoscopy endonasal approach. Actually, I refer all the tumor confined to the midline, even the tumor is extending in the third ventricle. I refer most of the cases to my colleagues. He is doing very good job in endoscopic approach. But for some complex pituitary tumor, for example, they involving the cavernous sinus. In this case, although the tumor is not so big, but actually is almost totally within the cavernous sinus. So I prefer transcranial approach. And actually for this case, I almost do the extradural approach to remove the tumor. I didn't any expose the intradural structures. And for more complex tumors, they extend in procedurally or laterally, or even more complex in the pretemporal space. Then such cases, I prefer transcranial approach to remove these tumors. For example, in this case, the tumor is invasive and complex. They extending far beyond the cavernous sinus in the suprasellar, outside the carotid artery. And in this case, I do the transcranial cavernous approach. So how I do it, as I mentioned, at the beginning, I already peel the temporal dura off the lateral wall of the cavernous sinus. As you can see, this is a lateral wall. So you can see I already removed the anterior clinoid. So you can see this is the clinal portion of the carotid, and this is the oculomotor nerve. This is trochlear. This is V1, V2. Since I already removed the anterior clinoid, so I can debulk the tumor first. Then I can localize the carotid in the clinal portion. So I started from the superior wall of the cavernous sinus. Then if you, with the tumor debulking, then you can trace the carotid. Of course, you already removed the inner membrane, so you can trace the carotid into the cavernous sinus. Of course, you, by mobilizing the oculomotor and trochlear nerve, you can widen the space. Then you can go with the carotid into the cavernous sinus. Then you alternatively open the triangles between each nerve. For example, you open the so-called supratrochlear triangle between the third and trochlear nerve. You remove the tumor, then you localize the carotid. As you can see, you localize the carotid and it's going from the clinal portion into this space. And with tumor removal and with the wider of the space, then you have to localize the abductor nerve beneath the fourth nerve and V1 branch. And following the sixth nerve, Then you could go down to the duodenal canal, just in proximity to the trochlear nerve. And also you can delineate the whole course of the carotid. As you can see, this is a clinal portion of the carotid and go into the cavernous sinus and go posteriorly at the posterior band. This is the posterior band of carotid in the Parkinson triangle or the supratrochlear triangle. So you can see the abducent nerve very well down to the duodenal canal between the V1 and trochlear nerve. Then stepwise, you open the space between the V1 and V2, so-called the anteromedial triangle, then open the space between the V2 and V3, so-called the anterolateral triangle. And you remove the tumor, and also you follow carotids to the foramen lacerum. Then you can backward to remove the tumor in the suprasellar region by our interpeduncular fossa and suprasellar region. So as you can see, this is the whole course of the carotid. This is the pecon and oculomotor nerve. So in this way, step by step, I can claim and totally remove the tumor in each corner or in each triangle between all these important neurovascular structures. So the patient is doing good. For most of the cases, patient will develop transient post-op oculomotor palsy, but I will refer them for acupuncture, and it is very good and useful for oculomotor recovery. And also in this case, similar is complex invasive pituitary microadenoma. I do the transcavenous approach with this case. So this video show the first step, I thinning the lateral orbital wall, and I can open the superior orbital fissure. So as you can see, there's a dural groove beneath the superior orbital fissure. So I need to divide the dural fold, including the meningoorbital artery. Now using the sharp dissection to make the cleavage plane very clear between double layers of dura. And then I push the dura backward, and you can see the tumor almost bulging out and the nerve overlying the lateral wall of the cavernous sinus. So this is the V1 branch, and this is the V2 branch, and this is trochlear nerve. And for the oozing from the cavernous sinus, I usually inject the T-seal between the V1 and V2. So as you can see, I continue peeling the dura and until I totally expose the lateral wall of the cavernous sinus. And I remove the anterior clinoid. I skeletonize the optic canal. So you can see, actually, most of cases, the anterior clinoid is eroded by the tumor. And I carefully thinning the bone overlying the optic canal. So you can see this is optic nerve. Then I cut the dura along the cilium fissure down to the base and extend the incision. Then I open the phospholigament to free the optic nerve. As you can see, the tumor already pushed the optic nerve against the phospholigament. So you have to remove the ligament at the beginning. Then I remove the outer ring overlying the carotid to mobilize the carotid and widen the space between the carotid and optic nerve or the carotid and the oculomotor nerve. So I open the inner membrane, I open the superior wall of the cavernous sinus, then I can remove the tumor. So you can see I trace the carotids into the cavernous sinus by opening the inner membrane and by opening the superior wall of the cavernous sinus. So you can see this is the carotid and where they enter the cavernous sinus. Then I can debulk the tumor and push. You can see this is the differential. Following debulking the tumor, you can easily push the differential downward. I don't cut the differential because I try to keep all the surgical procedure is in the extradural way. Then I open the triangle between each nerve. In this case, I open the Parkinson triangle. As you can see, this is the V1 and this is a trochlear nerve. I free the trochlear nerve down to the tentorial edge, and I remove the tumor, and you can see several branches from the carotid. This is the meningohypophyseal trunk. One is supplying the posterior lobe of the pituitary, and one is supplying the clivodura, and one is to supply the tentorium. Then I localize the intracavernous carotids. So in this stage, I need to localize abductor nerve. Because you can see, this is abductor nerve overlying the carotid. Then I remove the tumor in the posterior wall of the cavernous sinus. So I delineate almost the whole course of the carotid. Then I open the space between the V1 and V2. Then continue the tumor removal. For me, the transcranial approach, the most difficult part is the dead corner below the V1, whereas the oculomotor and trochlear, they conjoin beneath the supraorbital fissure, because you cannot see this is the dead corner. So you have to follow the carotids below the supraorbital fissure. And sometimes you need to do the endoscopy assisted to check if you totally remove the tumor. Then I push the posterior wall of the tumor of the cavernous sinus to make sure that I already remove all the tumor. As you can see, the tumor push all the dura. So you just do the, like you did the endoscopic approach, I do the subcapsular removal of the tumor. So you push the differential down and push the posterior wall anteriorly and check each corner. As you can see, the tumor is already going extended posteriorly beneath the mesiotemporal. So you have to cut the ring-like structure surrounding the oculomotor nerve to minimize the traction injury to the oculomotor nerve. As you can see, I free. This is the trochlear nerve, sorry. And the medial side is oculomotor nerve. So you have to check each corner to clean the tumor very well. So this is after surgery, I almost free all the nerves and vessels in and out the cavernous sinus. And the last step is put big fat pads, and I just using the Duracell to make the repair. So in endoscopy approach, as you already know, there are KNOSP classification with regards to the tumor recession and functional remission. But what about the classification by transcranial approach? So I believe that with more knowledge about the cavernous sinus and the advanced techniques dealing with the cavernous sinus, maybe the transcranial approach to pituitary tumor will be revived. And also there will be some new classification as regard to the transcranial approach to such kind of lesion. So in the past 15 years, I have done several topics of hands-on dissection course in Taipei, because I learned a lot from my teachers, and then I know that for different kinds of surgeries, the most important is the anatomy. So you have to spend time in the lab to learn anatomy, then apply your knowledge to your patients. So the patient will benefit a lot from your surgery. So today, my talk actually is one part of my course. Actually is hosted by the Iskra Academy, and we have the Cavernous Sinus course. It's actually the global course by Iskra Academy, and welcome all of you to join our course, and we can share our experience together, and we can grow together. So thank you very much, and I thank Professor Raja and Murad again, and also the Professor Yoko Kato inviting me, and it's my honor and pleasure to join this great ACNS educational program. Thank you very much.
Thank you, Professor Sanford. This is one of the best lectures I heard about the transcavernous surgery. Even better than Ali.
No.
Yeah. he have not heard that. And I think the knowledge you have about the cavernous sinus is very, very precise. It's very, 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 very good. And I agree completely with you about the transcavernous surgery. I think the 21st century transcavernous surgery must be redefined, especially about the application of the surgery in pituitary tumors and meningiomas. Because most of the publications said that if you go through the cavernous sinus or inside the cavernous sinus, the prognosis of the oculomotor nerves is very bad. But it's not true. It's not accurate, because the surgery of the cavernous sinus changed a lot in the last few years, especially for Ali Krish. I think that Ali Krish is one of the surgeons that make us all believe that the transcavernous approach is good. And the cavernous sinus is not only like he said, no, you know, the cavernous sinus is not a destination only. It's a pathway. You can go to the posterior fossa using the cavernous sinus, but the people is afraid to use the cavernous sinus because they don't know the anatomy, how to deal with the venous bleeding, how to deal with arterial bleeding, how to preserve the nerves, and a lot of concepts that you show today. I open the panel to any comment or question, but I congratulate you because this is one of the best lectures I've heard about the transcavernous approach. I agree completely with you.
Thank you, Professor Mura. Thank you very much.
Thank you very much, Professor Mura. May I ask one question to Professor Sanford? So, what are the immediate post-op outcomes with regard to oculomotor nerve in your series?
Yeah, actually, I didn't have any permanent post-op oculomotor nerve deficit, because as I mentioned, I tried to free all the nerves at the beginning of the surgery. If they are free, for most of the time, if you listen to the lecture, my teacher, Dr. Krish, he always take the example for the nerves. For example, when you deal with these nerves, it's like you play guitar. If you put too much stress over the string, and it is easily to make damage to this string. You may tear the string. But if you loosen the string, then the nerve becomes relaxed. So as I mentioned, you can widen the space between the nerves, but minimize the traction over the nerve. So this is the key to do the cavernous sinus surgery. So this is why my teacher, Dr. Krish, when he had a course, he named unlocking the cavernous sinus. The key word, unlocking, it means that you have to free the neurovascular structure from where it is anchored to the dura. So you have to do these steps at the beginning. Another example is the tuberculin cellular meningioma. What Dr. Amati always emphasized, you have to remove the phospholimin at the beginning when you deal with the tuberculin cellular meningioma. Because every time you open the dura, when you cut the phospholimin, you can always see the indentation over the nerve, because the tumor always push the nerve against the phospholigament. So at the beginning, if you cut the phospholigament and free the optic nerve, you will minimize the post-op vision problem after you do the tuberculin cellular meningioma. So this is very important, is to free all these nerves from the dura.
As it is expected, some amount of oculomotor palsy may be there. Do you recommend use of steroids in your postoperative period?
Yes, I will using the megadose of mesoprezolone, the steroid, for 3 days. But as I mentioned, I refer all the patient with the symptoms to acupuncture. I believe the Chinese acupuncture will fasten the recovery of the nerves.
That's a very new piece of information. Yes, my co-host, Dr. Liu Boon Singh, any comments from you?
Thanks, Raja. Thanks, Professor Stanford, for a very nice lecture. Professor, I want to know whether your approach transcavenous only limited for functioning invasive macroadenoma, or also you also targeting non-functioning, and is this technique enable you to have a zero remission as you show in one of the study, and in those recurrent cases, would this technique will enable a better treatment with radiosurgery later? Thank you, Professor.
Yes. At the beginning, I mentioned, actually, I refer most of the case for endoscopic approach. I only use the transcavenous approach for huge and complex cases. In such cases, the most of the patients already have the functional problem. But of course, most of the patients, actually, they develop the visual problem with the non-functional tumor. For limited case series, or in my experiences, as I mentioned, I didn't have any like a permanent palsy, but for the function remission, it's around 50%. Because as you can see, I deal a lot of case is already huge, and patient already had the functional deficit. So for the remission rate is lower, surrounding the 50, lower or not up to 50%. So this is the case selection, the problem with the case selection. But for the simple case, if you're using the endoscopic approach, like I mentioned, the KNOS classification, the smaller the case, you can achieve higher total resection rate and higher functional remission rate. But in transcranial approach, usually you deal a lot of tumors. Of course, the remission rate is not so optimal than the endoscopic approach, but I believe it's related to the case selection. But I believe for such difficult cases, even you using the endoscopic approach, it's very difficult to get a higher resection rate. So I'm thinking, for such a case, sometimes we can do the endoscopy assisted transcranial approach. So I can optimize the tumor resection rate. But of course, you have the good selection of cases. So fortunately, I have very good colleagues. He's a distinguished and famous surgeon doing the endoscopic approach. So nowadays, we try to have a collaboration and get a teamwork to deal with such kind of cases. And maybe after the case series, we can publish our result. Yeah.
Thank you.
Thank you very much. If there are no more questions, we can have Professor Vijay Shekhar. Would you like to comment anything? Professor Vijay Shekhar is mute. Yes, Professor Vijay Shekhar, any comments from your side? Kindly unmute your mic, Professor.
Very wonderful presentation with illustrations. I congratulate you, sir.
Thank
Very
you,
nice.
Professor Shekhar.
Thank you very much. With that, we can go to our chair, Professor Jorge Mura, to hear his comments.
Yes, I think when nobody talks, it's because everything is clear, or sometimes because when we are shocked because this presentation was so good. And I think that I said before that the main lesson that I learned today with Professor Sanford is the transcavernous surgery is safe. Transcavernous surgery can help patients, and it's not the meaning of a transcavernous surgery that you leave a patient with deficit. I think that it's very important to the young people to understand, the young guys, the young neurosurgeons, to understand that the transcavernous surgery is alive. And I think with good neuroanatomical knowledge and a good application of fusing glue and the control of the nerves, you can obtain very good results that we saw before with Professor Sanford. Thank you very much to everybody.
Thank you very much. I think with that wonderful comments and beautiful presentation, we can wind up today's webinar. I would close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Vijay Shekhar and Professor Sanford Su, and the chairs, Professor Girish Menon and Professor Jorge Mura, for the time and support for the educational activities of the ACNS. Special thanks to Professor Shivin for broadcasting this webinar on the WeChat channel, and also a special thanks to my co-host Dr. Libun Singh for joining in me today. So until we all meet on next Wednesday, it is bye-bye from all of us. Thank you very much for joining.